The Location-Based Resect and Discard Strategy for Diminutive Colorectal Polyps, a Prospective Clinical Study. Introduction. Optical polyp diagnosis based on image-enhanced endoscopy, IEE, allows for classification of diminutive polyps into neoplastic or non-neoplastic. As the majority of colorectal polyps found during colonoscopies are diminutive, 5 mm or less, and have a low risk for harboring advanced histology, replacing histopathology evaluation with optical diagnosis has been deemed a cost-effective and safe alternative. This potential for cost savings has led groups such as the American Society for Gastrointestinal Endoscopy, ASGE, the British Society of Gastroenterology, BSGE, and the European Society of Gastrointestinal Endoscopy, ESGE, to issue guidelines to support and guide the practical implementation of the resect and discard strategy. The ASGE Technical Committee, in its Preservation and Incorporation of Valuable Endoscopic Innovations, PIVI, statement, recommended the implementation of the resect and discard strategy if it reaches 90% or more agreement with histopathology in determining post-polypectomy surveillance intervals. However, the ASGE position paper emphasized that optical diagnosis should be performed by adequately trained, monitored, and audited endoscopists to increase the accuracy of optical diagnosis and the proportion of high-confidence histology predictions. The ESGE considers training in optical diagnosis as an important prerequisite for the implementation of IEE and recommends the use of validated classification systems to support the use of optical diagnosis with advanced endoscopic imaging along with sufficient photo documentation. Although the concept of resect and discard presents a great potential to improve colonoscopy practice, its widespread clinical implementation has not been achieved. A recent survey revealed that endoscopists have failed to adopt the use of the resect and discard strategy in clinical practice because of concerns about making the wrong diagnosis and subsequently an erroneous surveillance interval assignment with its potential medico-legal repercussions. To circumvent the problems associated with optical diagnosis, the authors developed a simplified and operator-independent resect and discard strategy. This location-based resect and discard, LBRD, strategy does not rely on optical diagnosis and does not require any special operator skills to be acquired or audited. The group has recently published a retrospective study evaluating this concept. The aim of the current prospective study was to determine how the LBRD strategy would perform in a prospective cohort when tested against optical diagnosis. Methods. The study evaluated a resect and discard strategy that uses the anatomical polyp location to classify colonic polyps into non-neoplastic or low-risk neoplastic. All rectosigmoid diminutive polyps were considered hyperplastic, and all polyps located proximally to the sigmoid colon were considered neoplastic. Surveillance interval assignments based on these a priori assumptions were compared with those based on actual pathology results and on optical diagnosis. The primary outcome was 90% or more agreement with pathology in surveillance interval assignment. Results. 1,117 patients undergoing complete colonoscopy were included, and 482, equaling 43.1%, had at least one diminutive polyp. Surveillance interval agreement between the location-based strategy and pathological findings using the 2020 U.S. Multi-Society Task Force Guideline was 97.0%, surpassing the 90% or more benchmark. Optical diagnoses using the NICE and SANO classifications reached 89.1% and 90.01% agreement, respectively, and were inferior to the location-based strategy. The location-based resect and discard strategy allowed a 69.7% reduction in pathology examinations compared with 55.3% NICE and SANO and 41.9% WASP with optical diagnosis. Conclusions. The location-based resect and discard strategy achieved very high surveillance interval agreement with pathology-based surveillance interval assignment, surpassing the 90% or more benchmark and outperforming optical diagnosis in surveillance interval agreement and the number of pathology examinations avoided.